An Evaluation of Self-Injury in Psychiatric Ethics by Grace Murphy. Self-injury is an umbrella term coined to represent any type of injurious behavior an individual afflicts upon themselves. This could involve, but is not limited to, cutting, burning, acting in a reckless manner, and so on. Self-injury, in the terms at which I will be describing in this presentation, is being used to overcome severely unpleasant mental states. In this presentation, we will use the example of psychiatric patients. I will examine the works of Carey Guttridge on assisted self-harm as a technique to aid in patients in severely unpleasant states to curb things such as severe danger to themselves or suicidal thoughts. Carey Guttridge, in her paper, Safer Self-Injury or Assisted Self-Harm, looks into the ethics behind the practice of self-injury as a practice method on psychiatric patients. She addresses how the practice of medically overseen self-injury has been addressed as assisted self-harm, safer self-harm, or harm minimization. She is specifically looking into the term assisted self-harm. She does this as she believes it has a negative connotation, while the other two terms have a positive form. By using the supposedly negative term for assisted self-injury, she begins her writing to examine if the approach is more likely to minimize harm by ensuring safer self-injury. These scenarios set up 4 questions to be answered. 1. What makes the healthcare practitioner responsible for the self-injury of the patient? 2. If 1, is the practitioner thus accountable for the self-injury? 3. If 2, is the actions of the practitioner immoral? And if 4, what does the obligation to a patient to remove them from a harmed condition permit for the healthcare practitioner? To answer question 1, we must look at what is self-injury, and can it be caused by acts of omission? Is self-injury still self-injury if it is being supervised and allowed to happen? Guttridge would say yes. It is happening through omission. Guttridge examines that injurious behavior happens through cause and consequence, something that if followed back can be traced to omission. Guttridge rests on omission, in the instance of allowing a patient to self-injury or not confiscating their self-acquired cutting implement, is only cause if and only if the event, self-injury to the patient, occurs where should the omission not have happened, the event would not have occurred. If cause is present, it must then be examined if the cause is relevant. The omission as relevant cause is a debated topic. Philosophers such as McGrath argues that a cause is relevant if you were not originally to perform the omission. Furthermore, philosopher Feinberg argues that the cause is relevant if the agent, in this case the healthcare practitioner, is required to act due to duty or moral obligation, but does not. As the healthcare practitioner has a duty to the patient, the omission of action when self-injury occurs is relevant. Although the choice to let a sharp object remain in the psychiatric ward is relevant and significant, does it make the healthcare practitioner blameworthy? Guttridge argues no. Guttridge argues that no matter the relevance of the cause, a healthcare practitioner would only be morally culpable in the case of self-injury if they encourage the self-injury. Healthcare practitioners aim to reduce injury escalation. That way, by allowing them to self-harm, they are in turn trying to prevent things such as suicide. Second, the intention not to increase injury nor use self-injury beyond the helpfulness of its use. Therefore, even though the cause is relevant, the healthcare practitioner is not blameworthy, no matter if omission does lead to the events of self-injury. Now that we have answered question 1, and we found that the practitioner is relevant to the particular outcome regarding self-injury with the patient, to answer question 2, is the practitioner accountable for this, we must look at the accounts of autonomy. As the healthcare practitioner has decided to not remove the injurious tool from the self-harming person, it must be asked if this makes them accountable for the actions of the patient. Not in the terms of omission, but in autonomy. It must be seen if the patient has complete bodily autonomy. If the patient does not have complete bodily autonomy, the healthcare worker is inadvertently making a decision for them by not taking away the cutting implement. Guttridge says that not meeting the standard for bodily autonomy makes a patient substantially non-voluntary. This means they do not have individual control over their decisions. To achieve bodily autonomy, there are 3 standards that must be met. 1. Having standards of endorsement. 2. Free formation of desires. And 3. Agents of self-worth. If a patient does not possess these 3 standards, then they do not have complete bodily autonomy. Therefore, the healthcare practitioner does partake in making some form of decision for them. If this is the outcome, though, who is responsible for the result of what happens when the practitioner does not take away, for instance, a cutting implement? The problem in question is the patient is not completely involuntary. They do have some form of control and decision-making over themselves. In this instance, the patient is what we call minimally voluntary. So if the practitioner is fully voluntary and the patient is minimally voluntary, we must ask who is responsible for the outcome. In this instance, they both are. They both partake in some form of responsibility for what happens to the patient in result of the practitioner leaving a minimally voluntary person with, say, a cutting implement. Therefore, this answers the question that the practitioner is partly accountable but not wholly. Now that we have come to the conclusion that the health practitioner is not fully accountable but partly accountable along with the patient, we must look at the actions of the healthcare practitioner are moral or immoral. To figure out if the actions of the healthcare practitioner are immoral, we must first divulge if the patient is being inherently harmed. Therefore, we must ask, what is harm? According to Feinberg, harm is the act of repressing or acting against one's own interests or violating an individual's rights. In the terms of our example, an interest can be something such as bodily integrity. By this definition, self-injury seems inherently harmful to the patient, and the healthcare practitioner, by allowing it to happen, is acting immorally. Despite Feinberg's point, Guttridge has a different take on harm in the situation of self-injury. Guttridge proposes, take action X, and action X is harmful. The act, and whether it is truly a condition of harm, can be found in the history of it. From this point, one can trace back and see if by participating in action X, the patient has improved or regressed. Guttridge does not see the clear distinction with harm as Feinberg does. She believes it to be relative. She acknowledges that being in a harmed condition is absolute, but harm itself is dependent on the circumstances. That is how a patient can participate in a way X that is harmful, but not be inherently harmed. Therefore, the practitioner would be acting morally. She agrees that practitioners have an obligation to remove their patients from harm conditions if the patient cannot remove themselves. But if self-injury as a medicinal practice is beneficial, then the obligation ceases, as it is not a harmful condition. It must be seen through history if self-injuring harm is actually beneficial, more so than non-self-injuring, in removing a patient from a harm condition, as the condition is the absolute form. In this case, the condition being their own mental state. If participating in self-injury will eventually remove the patient from the harmed condition, then it should be allowed. Until a clear answer is defined on whether this happens, Guttridge rests the practitioner is not acting immorally. Now that we have answered the question of morality and resolved to the patient health practitioner problem, we must look at what is the obligation of the health practitioner to remove a patient from a situation regarding this factor. Guttridge rests on the idea that healthcare professionals are not obligated to remove their patients from harm's way. Take the instance of removing a cutting, inflicting object from them, if they are ensuring absolute harm does not occur and that the self-injury taking place is working towards enhancing a patient's autonomy and overall condition. The obligation relevant to healthcare practitioners is to prevent overall harm, and if allowing a relevant harm to occur is preventing a harmed condition, then practitioners are justified in allowing self-injury to happen. This is the case because of absolute harm versus relative harm. Absolute harm being morally bad and relative harm being not morally bad allow for the distinction between the two to occur. This is because relative harm is governed by a person's own normalities. If cutting themselves is a normality, then supervised would prevent less harm in the long run. It is morally acceptable for a healthcare practitioner to allow it to happen to their patient, perhaps sidestepping their obligation to prevent any harm from happening to their patient. Meanwhile, absolute harm is governed by the absolute picture of what harm it is. It is independent of an individual's own normalities, meaning if allowing a patient who would not normally express themselves through self-injury to self-injure, the healthcare practitioner would be morally wrong, and their obligation to prevent their patient from self-harming would occur. This paradoxical arrangement between the two harms rests on the judgment of the healthcare practitioner to decide if they are allowed to allow relative harm to happen for the sake of removing a patient from a harm condition. In closing, the current understanding of self-injury and how it can affect behavioral change are acceptable and therefore healthcare practitioners are justified in their actions of allowing supervised self-injury as long as they ensure absolute harm does not occur, and the self-injury is only done in the attempts to propel forward a patient's progress, remove them from harm conditions, and increase their capacity towards autonomy. Guttridge paints the moral dilemma of allowing self-injury upon a patient for a healthcare practitioner. She rests on the concept that until more history is developed on psychological pros and cons on self-injury, the practice is justified in the place of health practitioners, as long as no substantial absolute harm occurs to the patient. Thank you.